All right. So, welcome everyone. As you all know, my name is Corey Lubring, and I'm the PBRN coordinator at DO-Touch.NET. And thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. First, please feel free to introduce yourself in the chat and tell us where you are from. We also would invite everyone to turn their cameras on so we can be united as an OMM research community. Second, if you're having technical issues during the webinar, please put a message in the chat. Third, if you have questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. We will also have time for discussion and questions at the end of the presentation. And last, please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel once everything is completed. And so today is our Let's Talk About OMM Research educational webinar titled Using Osteopathic Manipulative Medicine on Preterm Infants in the Neonatal Intensive Care Unit to Reduce Neuromotor Developmental Delays. With Angela Tyson. And so Dr. Tyson completed medical school at Edward via College of Osteopathic Medicine, Carolina's campus in Spartanburg, South Carolina. She then completed her pediatric residency and OMM +1 residency with Oklahoma State University in Tulsa, Oklahoma. And then she completed her neonatology fellowship with the University of Rochester in Rochester, New York, where she is now attending. And Dr. Tyson has an interest in neurodevelopmental outcomes in preterm infants who receive osteopathic manipulations. So please help us welcome Dr. Tyson.
Hi there. Let me just share my screen. Okay. Can you all see this okay? Great.
Angela,
all right.
You see your presenter screen?
I don't know how to do that. How do I fix that?
There's that little button on the bottom that's got the TV with the half. Yes, that's, or no, I thought that switched it usually.
I see it. I have like 3 monitors. That's the problem.
You might just need to switch.
Hold on just a
which
second.
Screen you're sharing.
Yep. I don't know how to do that either. So sorry. This one?
Yes.
Oh, hold on. Ooh, that did not work. 1 second. That?
Yes.
Do you see the... You see that okay?
We see just the PowerPoint and we see it just fine.
Lovely. Okay,
Perfect.
great.
Well done.
Thank you guys. Okay. So this is a study that was a randomized control trial using osteopathic manipulative medicine on preterm infants in the Neonatal Intensive Care Unit to reduce neuromotor developmental delays. Dr. Degenhardt has been highly involved in this study with helping from the osteopathic portions of it. He's been part of my entire career development and is a big reason why I'm here today. So our study design and background, reviewing the purpose, hypothesis, and aims. Just to reiterate relevance of this, though you're all part of the osteopathic community, so you have a different insight to the value of this, but 1 in 10 babies are born prematurely each year. High likelihood of neurodevelopmental delays in those children. And we know that there are stuff that decrease neurodevelopmental delays, such as skin-to-skin, breastfeeding. We know all the therapies that do work, such as touch and massage, occupational and physical therapy. But regarding neurodevelopmental outcomes in OMM, it is not well studied. And another important background you'll need to know for this research project is what the TEMP is. That's called the Test of Infant Motor Performance. This is an extremely well-studied and reliable screening tool with high sensitivity and specificity for predicting neuromotor developmental delays within the first year of life. Many of you are likely familiar with the Bayley's assessment done on infants and toddlers, and then moving into the older children with the Bayley's score and the Bayley's test. This test can be converted over to a Bailey's comparison to then follow those later in life. But this test is unique, the TEMP, because it can be used in the NICU, starting at infants 34 weeks corrected gestational age and can be followed until 17 weeks past term equivalent age. So it is very valuable. It is the first neuromotor developmental screen that can be used in the NICU and is standard of care prior to discharge in many NICUs and is now part of ours. So the purpose of this study is ultimately to evaluate if osteopathic manipulative medicine improves neurodevelopmental outcomes for premature infants. The first step towards approaching this was for us to develop a blinded randomized control trial of preterm infants born less than 34 weeks, comparing the risk of neuromotor developmental delays as measured by that TEMP in infants treated with OMM compared to those who just received standard supportive care. Our hypothesis was that these high-risk preterm infants born less than 34 weeks who got the OMM compared to just standard of care would have increased neurodevelopmental scores on this TEMP. Our primary aim and the whole target of this project was to look for the difference in the TEMP scores between infants who receive OMM and those who only receive standard of care, with secondary aims looking to compare length of stay, growth parameters, and then percentages of subjects who received NG feeds or gastric feeds and G-tube feeds at discharge to see if there was a feeding difference as well, particularly focusing around the mechanism of feeding. We had a study sample size calculation done around a power calculation. And this is really important and lacking in a lot of research studies, particularly in osteopathic medicine. And this has been a really well-designed study, I think, as we did a power calculation based on a sample size of 126 kids, meaning there's 63 in each group. And how we came up with this is the TEMP is reliably scored in 2-week increments, so that if you repeat the test 2 weeks later and your score changes, that's been shown to have a statistically significant and clinical relevance to a difference in score leading to a difference in neurodevelopmental outcome. If it is repeated more frequently than 2 weeks, then it doesn't really show any statistical differences in a projection of where that kid may lie. So the test is meant to be repeated no more often than every 2 weeks, which would still be quite frequent. So that is why our TEMP is done between a 36 and 37 week interval and why we're looking at that. And we were looking for around 1 standard deviation to a half a standard deviation. Most studies published using the TEMP as a neurodevelopmental outcome test go within 1 standard deviation. So we got even more specific looking for a half a standard deviation, and that's based on a sample t-test with a significance level of 5%. So overall, to detect this 80% power, to detect a half a standard deviation, which is a score difference of 6.5 points on this test, we needed 126 subjects, around 63 in each group. What we did is we took infants born anywhere in our NICU as low as 23 and 0. We now resuscitate as low as 22 weekers, but when the study was started, we did not resuscitate 22 weekers, thus they were not included in the study. And we waited until they were at least 28 weeks corrected gestational age or born at least greater than 28 weeks corrected just at birth age to enroll them. The reason for that is most of the neonatal studies are published out of Italy, and there are very few studies or reports on safety acknowledging that this is safe to do on infants less than 28 weeks. So without that safety data being performed, showing that it can be done earlier than that, we decided that we would wait until 28 weeks. In addition to that, most of the PT and OT world also does not start until at least this corrected in birth gestational age, if not much later than that. All the infants in the study had to be deemed stable and safe enough to have osteopathic manipulation performed by an attending neonatologist, and obviously we had to have parental consent. So the inclusion criteria is really minimal. You pretty much just have to be born in the NICU. You are excluded if they had surgical interventions, not including a PDA ligation. Those are very standard of care and usually done in very stable, controlled environments for our infants. Other than that, if there were any other known surgical interventions in the NICU, those are likely to be done as a surgical emergency, meaning that that infant has significantly deteriorated and is already at a predisposed risk for neurodevelopmental outcomes that could not be compared to the normal baseline. Other things that excluded infants are other conditions that would automatically set those kids up for an increased risk of neurodevelopmental delays that would be an unfair comparison between the groups. Those included kids with any known severe neurological complications, such as large head bleeds, grade 3 and 4, any kind of neonatal stroke, hypoxic event around birth, neuromuscular diseases, various genetic metabolic diseases and cardiac diseases, and parents who were not able to consent in English. Osteopathic manipulation is a very unusual thing up here in Rochester, New York. DOs in general are unusual here in Rochester, New York. I did not feel comfortable consenting parents in another language. I wanted to make sure that I had open and fair communication with them. Thus, this consent for this study was only done in English. Study criteria on when to start encounters. Now, the Italian studies have done an amazing job on showing great stability and an approach through the NEO model on how to approach infants in the NICU. But when to start an encounter, we were really starting from scratch here when designing this study. The physical and occupational therapy world, as well as the neonatal touch and massage world, typically use factors for autonomic stability in infants to determine that they are going to handle care and handle touch well. And this happens to occur around 28 weeks corrected gestational age, or if they are born at least 28 weeks at birth age. These criteria are, they are no longer acutely ill and are medically stable. They can awaken spontaneously and remain awake after a stimuli ceases, such as cares and a diaper change or feeding. They can stay quiet and alert in a state for up to 10 minutes, 5 to 10 minutes after being stimulated. As most babies prior to 28 weeks corrected gestational age, if you touch them, they have a bradycardic, apneic, and desaturation event, and that is not unusual. They have to begin to notice and respond to their environment, begin to track with their eyes, want to start to seek out social interactions, and can maintain that physiological stability with cares. So every time a baby was in the study, they had to meet these autonomic criteria per what the nurse and the attending thought about each infant before they were able to truly begin any intervention in our study. We also had very strict, maybe too strict, looking back at it now, criteria on when to stop an encounter. While we were performing encounters, which we'll go through what an encounter involves in just a minute, if they had anything greater than 15 persistent seconds of an apnea event, a desaturation, a bradycardic event, really wailing and crying with persistent crying and pain, coughing, choking, vomiting, hiccups, tachycardia, tachypnea, or any arching that was significant and wouldn't stop within 15 seconds, we discontinued an encounter. How we decided what we were going to do in these encounters, first we had to go through a randomization. And researching neonates that are premature, one premature infant is not equally as compared to another by just classifying prematurity. So we further divided our kids not only into a treatment group and a control group, which were our two groups, but we did it within 4 gestational age strata. These gestational age stratas are listed below, and they are grouped based on the already known neurodevelopmental risk factors for just being born prematurely at those ages. Each one of those stratums were randomized 1-to-1 by a statistician, and I had 4 groups. So based on the enrollment time and the birth age of that subject, when they met all of these clinical criteria to enroll into the study and to begin interventions and met all of the inclusion and no exclusion criteria, I pulled a packet from whichever stratum that patient's birth age was born into. I opened an envelope and it told me into the treatment or the control group. So this was completely blinded to me prior to the study and done by an outside person. The methods for the treatment group involved an osteopathic exam, an OMM for a max of 15 to 20 minutes every 7 to 10 days. This occurred around a privacy curtain within the neonate's room. Only I and the neonate were behind the curtain. No nurse, no parent, no physician, no anybody else knew what was happening behind that curtain. And notice in the control group, I stayed in the room for 15 to 20 minutes every 7 to 10 days, also behind that curtain. So whether in the treatment or the control group, no one knew which group they were going into except me. And our rooms are just so nicely designed to be able to do this in. This allowed parents to stay in the room with their infant without having to leave the room, but also allowed for a blinded environment to what was happening behind that curtain. We have monitors within the room and outside of the room for our nurses to follow. And the stability and care lines, tubes, ventilators, all those things were checked prior to me touching the patient. If they were in an isolette, their top was popped, and everybody was treated the exact same for the setup of these encounters, whether they were in the treatment or the control group. The only difference is that in the control group, the kids just received standard of care. I just stared at their cute little bodies for a good 15 to 20 minutes behind the curtain, versus the OMM group received both an exam and a treatment that was appropriate for whatever dysfunctions they had. We have a sheet that ranked them in like a mild to moderate to severe dysfunction, and that's how we recorded it in every area of their body. And nobody was treated for anything they didn't have a dysfunction in. So sometimes these treatments lasted 5 minutes, sometimes they lasted 10, sometimes the babies loved it, and they would have lasted all day if I kept my hands on them as they got older. However, the study was discontinued by this 15-minute window. And that way I stayed within the control groups for the same. So the nurses and the staff really had no idea what was happening behind that curtain and what group the baby was in. My study discontinued for the encounters and meeting these babies every 7 to 10 days from this 28-week corrected gestation window, or whenever they were born after that, if they met the criteria, all the way up to 35 and 6 days corrected gestational age. This allowed me, by recruiting babies that were less than 34 weeks at birth, to at least get 2 OMM sessions in. And it allowed me to get up to 10 if they enrolled right at that 28-week corrected gestation window. So we kept track of how many treatments there were per infant, and they received around the same amount of treatments. And then my study encounters stopped. And after that, certified occupational therapists trained in the TEMP came in and performed the TEMP on these infants. The occupational therapist had no idea whether or not they were in the treatment or the control group. And I wasn't allowed to be part of this TEMP evaluation and did not have the TEMP scores on any infant until the entire study was concluded. This just kind of gives an overall view of how this study worked, starting with kind of just a timeline, as sometimes it's a little bit easier to follow when it's all laid out. So again, they could be born at minimum down to 23 weeks. They couldn't have an enrollment and start the study encounters until they were at least 28 weeks corrected or born at 28 weeks or greater. My study discontinued when they were 35 and 5 gestational age, corrected gestational ages, and then I was all done, and in came the TEMP provider to perform the TEMP at least once between 36 and 37 and 6 days corrected gestational age. And then after that, the study was concluded for that infant. We did continue to monitor certain parameters prior to all subjects until they were discharged from the NICU. This was just a timeline of things. This was actually a study that started when I was a neonatology fellow and finished as now I'm a neonatology attending. So this was just a timeline of how things went. COVID happened. Yes, it did. So that threw the timing of things off for sure with enrollment and starting clinical trials. For a while, things were shut down. So that altered some things. There were some personal changes. I broke my leg in the middle of the study and had to take a leave. And just babies in general, sometimes they get transferred to other hospitals if they're stable enough. Sometimes they're transferred in and transferred back out. Sometimes they had to be withdrawn because they became clinically unstable and met one of those criteria for exclusion midway through and needed a surgery or became clinically unstable. So those things really factored in. And then the budget. The cost of the study was budgeted in right under $10,000. And really the only cost of this was to pay the occupational therapists to come in and do the TEMP and the cost of these TEMP booklets that were needed for the study. There was thousands and thousands of research dollars available for me to do this study, and I was 100% funded. The actual cost of the study was right at $9,500. I received funding through 2 internal grants at Rochester and then through the LBORC, through the American Academy of Osteopathy for additional funding. Results. Getting to the cool stuff now. So this just shows you differences amongst the 2 groups. As you can see, everything needed to be balanced around these parameters. And there were some neonatal morbidities that we looked at. And we're not really quite sure if these are co-founders where the groups were imbalanced, or that the things that we're looking as co-founders and statistically different amongst the groups could actually be a reflection of the treatment, such as bronchopulmonary dysplasia, which is defined as an oxygen requirement greater than or equal to 36 weeks corrected gestational age. There is a statistically significant difference in the people who were treated with OMM versus those who were not, with BPD being lower in the treatment group. As for now, we considered it a co-founder, and we balanced the groups out statistically based on those co-founders, as well as interventricular hemorrhage. There is statistically lower rates of grade 1 and grade 2 interventricular hemorrhages in infants in the treatment group than in the control group. Most of these babies would have had head ultrasounds and things performed to screen for IVH prior to me ever putting my hands on the patients. So there may have been a slight difference in the groups, but could it be related to the fact that these improved, or especially for some of these babies born in that 28 to 32 week window, there is a strong possibility that I could have performed OMM on them before they got their head ultrasounds. Those head ultrasounds aren't always done until 6 weeks of life or potentially later. So is it a treatment effect, or is it a confounder? Right now, they're factored in as confounders. Other than that, these are our overall results with those things being balanced out. So what we saw is our TIM scores were definitely higher in the kids who received OMM versus the kids who did not. So not only did we, again, we were targeting, it was powered at 80% for a half a standard deviation. We were able to see greater than a full standard deviation differences in all of the stratum. So what is nice about this is not only are they statistically different overall, but they are almost equally statistically as different within each individual cohort of each stratum for each gestational age, which is great. That even provides more evidence that this is meaningful and consistent. So this means that kids overall have a statistically significant lower risk of neurodevelopmental delays within the first year of life receiving OMM for those who did not. Our length of stay was almost identical to things in the Italian studies. I remember when I presented this to our group in Rochester and said the Italians do OMM and they get a reduced length of stay sometimes by 2 or 3 weeks, and people thought I was crazy, and that is exactly what we got, almost verbatim. So it's, again, consistency that OMM provided to preterm infants gives a similar decreased length of stay, and my data is very consistent to what the Italians saw as well. You see a very significant difference in length of stay almost by 40 days in the 23 to 24 weekers, but take into consideration there were just a handful of patients that qualified for the study that were actually born that early. So it is very difficult to interpret and make an actual statistical inference on that. However, in all the other groups, there were pretty large sample sizes within each of the stratum individually. So it is statistically different overall and amongst all of the stratum, but I don't feel comfortable saying that that really big jump in the very, very small babies we can put much information into because it's such a small group. Overall, our mean difference for length of stay was an 18-day difference. And even if you see these 32 to 34 weekers who were treated that only maybe got 2 or 3 episodes of intervention, there's still days differences in the length of stay. That is also cost effective as well as good for the families and the infants to be able to go home from the NICU. So this is great information as well. And then feeding outcomes. The Italians have done a really good job of looking at weight gain and gastrointestinal reflux, constipation, and have well proven that. But looking at the mechanism of feeding of infants at discharge has not been something that's been thoroughly investigated at. So we not only looked at feeding at discharge, but we ended up looking at the feeding at 36 weeks corrected gestational age as well. And the reason that we picked that timeline was because that is when my encounters or interventions on these subjects actually stopped. So there's a lot of things that could have happened between 36 weeks corrected gestational age and discharge. So we were curious if babies had an improvement at the end of my treatment encounters as well, in comparison to how they actually did going home, and if those things could be consistent, and sure enough, they are. So when we looked at this, we first had to determine if there was even a statistically significant difference in the types of feeding amongst the treatment and the control groups at 36 weeks, and there was. So that gave us evidence to dig further and individually. I was particularly interested in looking at only those who were full PO feeding by 36 weeks corrected gestational age. Now, take into consideration the suck, swallow, and breathe reflex usually doesn't kick in until 34 to 35 weeks at the earliest. So full PO feeds in an infant that is not requiring any NG feds, particularly being born prematurely, is very rare to have them full PO feeding by that time, and most babies require some NG fed. So if we were getting infants to PO feed higher overall by that timeline, that is very significant to our neonatal population. And sure enough, what we saw is the treatment group has a higher rate of all PO feeds at 36 weeks compared to the control group, with 34% of the subjects full PO feeding by 36 weeks in comparison to only 10% of infants in the control group. We then looked at the same data at discharge. Instead of looking at who had PO and NG feeds and NPO, meaning they don't eat at all, we then looked at what was happening at discharge. No infant goes home not eating, right? So they got to eat through some mechanism. And by the time they were discharged, a lot of infants were receiving G tubes. Now, not every NICU in the country discharges home on NG feeds. We do a lot, and we will advocate for an infant to go home NG fed unless they have a very clear indication to have a surgical intervention for a G tube. Studies have been shown that neurodevelopmentally infants do much better with NG tubes if they can go home with that and be PO feeding by 3 to 6 months of corrected gestational age life, which is what we see. So it is very rare for our surgeons to put in G tubes here. So just take that into consideration. Overall, out of the 126 subjects that were in this study, only 8 G tubes were performed altogether. Only one of them was in the treatment group. So what we see here for feeding data is, again, feeding data at discharge. There is a statistically significant difference amongst feeding in the treatment and the control group. So again, we went digging further. I was interested in only the rates of G-tube, finding only one in the treatment group, whereas 7 G-tubes were performed at the control group. So that is, again, a very low number to compare, but considering out of 126 kids and the very low rate of G-tubes performed at our institution, only 1.5% of the treatment group had a G-tube versus almost 10% of the control group. So it is still statistically significant, but anytime numbers are this small, it is always difficult to make an accurate inference. And looking at growth, did I skip the PO feeding? Sure did. And then again, we wanted to know what the PO feeding rate was at discharge. So again, we were able to discharge these babies a lot earlier than in the control group. So you would think that often people are going to go home with more NG feeds if they're getting out of there so early in comparison to the control group. But that is not what we saw. We not only saw a decreased length of stay, but an increased rate of PO feeding at the time of discharge, with 67% of children going home with full PO feeds and only 33% of children going home with all full PO feeds at discharge otherwise. So we had a much higher rate of all PO feeding at time of discharge. So growth parameters. This was really, really challenging. And the Italians put together a study literally over a decade of multiple compiled sites to come up with trying to prove a difference in weight and growth parameters. The way our growth parameters are measured are both with z-scores and at, centimeters and kilograms or grams of weight gain on every Monday. Now, we have additional data points on the day of birth and the day of discharge, but so much varies in between there. So much varies per attending that it is very challenging to make adequate inferences over actual growth. So we did not see a statistical difference in the growing of each of these children or significant growth parameters. We are working with our statistician to dig a little further to see if we can clean up, but there are so many confounding factors in this data that it makes it very complicated to accurately infer. Other things we did throughout the study and when we designed this study was trying to figure out when to start, how long they were going to tolerate OMM for, were they going to tolerate OMM well, how do we know when to start and stop? So we were very particular about recording the time of treatments tolerated for each encounter. So again, we had all those very strict discontinuation criteria that if they did this for more than 15 seconds, all bets were off, the encounter was stopped. But remember, that was the same criteria for whether I was touching these children or I was just behind the curtain staring at these cuties. So what we see is that, can you guys even see here? So, oh, I'm so sorry. So consistently in all of these, you'll see that the treatment group is in red and the control group is in blue, and those carry forth to the colors here. I'm sorry that didn't go well. So you can see that the duration for how long a kid tolerated a treatment is almost identical between all of the groups. Now, what you see in these three bar graphs is broken down by the stratum of gestational age that these babies were born into. So stratum 1 and 2, with the micropreemies 23 to 24 weeks, with them being only a handful of subjects, they were looped in and combined for this data into the stratum 2, which was 25 weeks to almost 28 weeks corrected gestational age. Those kids are getting interventions by the time they're 28 weeks corrected gestational age in almost all circumstances because they're that old. When you get into these other brackets, you see blanks there because these kids weren't that age when they were born. So that's where the lack of data is coming from, is these kids were just born later in the game. And you can't compare that data. And what you see is for the earlier gestational age kiddos, they're all tolerating treatments for about 5 to 6 minutes at a time, but they're also only tolerating life for 5 to 6 minutes at a time when they are not touched either, meaning these kids are likely just to have an event every 5 to 6 minutes based on their gestational age. That's just what they can tolerate in a pop-top, open encountered situation. So the fact that they tolerate treatments for 5 minutes is a good thing. That's great. And it's also meaningful that it compares to a control group where they also tolerated life for about that long. So I don't think we can say that babies do not tolerate OMM for a long period of time at this gestational age. We just can say that there's not much of a difference in how they tolerate treatments, period. They all have these events around that time. So maybe our stop criteria was a little too stringent. And then we are looking at specifically the percent of adverse events by corrected gestational age here. What this means is taking this timely tolerated, where here you see these older kids, almost everybody tolerates a treatment for 15 minutes. Well, that was the cap of it. We didn't go past that timeline. So we're looking at reasons that I stopped an encounter and said, nope, this baby met this criteria. We have to stop the study. Now, obviously, when you go back and you look at these smaller babies only tolerating treatments for 5 to 6 minutes, of course, they all had some event. Of course they did, because none of them tolerated treatments for 15 minutes, but neither did the control groups. None of the control kids at 28 weeks corrected gestational age had event-free episodes either. So what we see is kids are just gonna event, period, when they're less than 30 to 31 weeks corrected gestational age. It doesn't matter if you're pop-top, if you're touching them, they're just going to do it. And, you know, this was interesting data and has sparked a lot of interest in our group looking at events in general for babies, because there's not a lot of good information to say how frequently a neonate at a specific gestational age should be eventing, should be, you know, desiding and bradying. It's just part of their neurodevelopmental state when they're that little, and we protect them as much as we can not to have events like this, but they're just going to. So this was helpful information to see. But what's very interesting is when we start looking at the kids either born or at a corrected gestational age around 31 to 33 weeks corrected gestational age. This is where we start to see a difference. And what we see is the control kids who were not touched at all actually had a discontinuation event where I stopped an encounter early because they had some kind of event versus the kids who were treated actually had less events. Now, the whole point of recording this was to make sure that kids weren't going to event more and that it wasn't unsafe for preemies. We did not expect to necessarily see lower events, and kids actually tolerate things better if they were getting treated. So we have a pretty statistically significant difference in tolerance of treatment, showing it to be beneficial with less events between babies who were born or corrected at 31 to 33 weeks corrected gestational age. And then you see just a handful of events that are outliers, all in red, of kids who were older. But almost every baby, by the time they are either born or corrected to 33 weeks gestational age and above, they're almost always going to tolerate a treatment for 15 minutes and do very well. So we learned a lot about the processes of how often neonates events and what it looks like between the control and the treatment groups in this study, and it gave a lot of helpful information. These are the types of adverse events that babies had, and they're very different between the treatment and the control group. Notice that there is much, much, much less oxygen desaturation events in the treatment group than in the control group. If I stopped an encounter in the treatment group, it was usually because they were throwing up or they were arching their back. Now, I almost always did an encounter on these infants before they required their feeds, but sometimes a nurse would start their feeds early, or the baby was hungry and actually all early feeding at that point, and they couldn't wait. So the vomiting was usually because their bellies were full. And the arching events may have been because they're just ticked off because this is at the time of their care and they want their food. They are hungry little babies. So, you know, a good almost 40% of the events for the reasons that I stopped a treatment, an actual osteopathic treatment, were due to vomiting and persistent arching. There's much less desaturation events in the kids, meaning that their oxygen saturation may indeed improve. Overall, there were more events in the treatment group, more events in the control group kids, with 32% of children in the control group experiencing some reason they had to stop an encounter prior to 15 minutes versus the treatment group had less. Overall, we can conclude that OMM used around weekly on preterm infants in the NICU results in better neurodevelopmental scores that predict how they do in the first year of life. They go home sooner. They have better rates of oral feeding and less G-tubes. The tolerance of treatments for about 15 minutes, once greater than 33 weeks corrected gestational age, whether they are born or corrected to that gestational age, they all tolerate treatment extremely well by 15 minutes. And the tolerance of treatments for at least 5 minutes can be shown as safe without adverse events in babies as small as 28 weeks gestational age, despite their birth weight or age. Questions?
All right. Well, thank you very much for that. Just a few reminders as we open the floor to all attendees for questions and discussion. If you would like to speak during the discussion, please raise your emoji hand, which is located at the bottom of the screen under the reactions menu. We ask that you briefly introduce yourself if you haven't already, and please feel free to turn on your camera while you ask your question if you would like. Second, when contributing to the discussion, please limit your microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. Jane, do we have a timer to assist with that? I know. Okay, Jane will be keeping time herself to make sure that we're keeping within that track. And after everyone has had an opportunity to make comments or ask questions, there may be additional time for comments and questions afterwards. And also, if you want to put them in the chat, if you don't prefer to say them out loud, us moderators would be happy to read any questions or comments in the chat, and feel free to address each other's questions or comments there if you would like. And we'll start with Dr. Joy for the first question.
Hey, it's Kelly Joy. I'm in Joplin and at Kansas City University. And I guess I want to say wow. If I can say wow for like 2.5 minutes and then just ask my question, then that would probably be the most appropriate.
Thank you.
But my question was, what kind of somatic dysfunctions are you finding? Is there a consistency with gestational age? And can you talk to about that for a minute?
Yeah. So there are very few somatic dysfunctions in these kids at all after they get a couple of treatments, which, I mean, to us, duh, right? Like, we don't see these babies back every week, every month. Like, that's not a thing, right? So, I mean, there were kids with like significant somatic dysfunctions if they were breech, for example, like, right, like they're going to be breech. Things that I didn't expect, that I don't think neonatologists think about or anyone's advocating for, is the position of these children that they have to be in for particular lines and tubes. I found significant extremity dysfunctions in kids who had PICC lines or former PICC lines in that extremity. There was very poor motion within their tissues and in that extremity joint up into their central trunk location. That's something that hasn't been published or noticed. And once this initial like wave of publications come in, the first data will be like on safety data saying like, hey, OMM is safe. Hey, this is when you can expect to treat a kid. And these are the parameters we did it. And then that paper will be referenced for all the big statistical outcomes for feeding and growth and the temp scores. And then we will release what we did with the OMM stuff. So we, determining somatic dysfunctions is not like they're going to be like, oh, this is a neonate with flexible little joints, side bend right, rotated left, a T2. Like, that's not a thing. So what we did is regionally, we decided we would define myofascial patterns as basically having a myofascial or a BLT dysfunction, whether it was mild, meaning that it took very little manipulation to make a difference in the tissues, moderate, where it took significant forces to make a tissue, and severe, where I could barely move it at all. So that was it. This region is moderate, this region is mild, this region is severe. And we were also trying to come up with categories to make it more simplistic, that if this worked, that I could make this explainable on layman's terms to someone who is not an osteopathic physician, to say, it took a little tiny bit of force, it took a pretty equivocal force, or I couldn't move it at all. People are going to understand that. And babies at this age, they're just a little gelatinous ball. So everybody was myofascial, cranially treated, very simple manipulations. Nothing was major direct forces. And the next question is, how much force is applied to make a clinical difference? Dr. Degenhardt, I already have her thinking caps on about that with this cool little gloves, measuring pressures. And, the next steps will be like mechanistically, like how much force does it take to do this? And how do we teach this to everybody else? So that was a very long explanation. Hopefully that makes sense. But lots of similar myofascial patterns. We learn about like Z lines and like alternating fascial patterns. Babies seem to have like a dysfunction all on one side or the dysfunction all on the other side. And then sometimes if they are like locked down in their neck and their head and their SCM and clavicle on one side, I find like that just parallels straight through to the sacrum and the pelvis on the other side. That seems to be the only similar dysfunction. I see a lot of people nodding heads. See, like, why don't we publish this stuff? We got to publish this junk. But like, that seems to be the only crossover somatic dysfunction. Otherwise, they're like rolling basically to where like everything on the right is locked down, or everything on the left is locked down, or just their pelvis is shut down, or just their thoracic clavicle inlet area is locked, and nothing else is wrong with them. But I don't find them like cutely alternating like we would expect in a child or an adult. They don't do that. So we have all their dysfunctions for every encounter, and like, I don't know, thousands of data points. I think altogether there was like 630 encounters, meaning that there were over 300 osteopathic encounters to compare information on. And though this was on only 60 something patients of encounters, it's still 300 data points to look at. So it's coming.
I think our next question was from Miriam Mills. You are muted. Oh.
I think Kim was ahead of me. No, okay. Did you do any Hi, Angela. I'm so proud of you. Did you do any correlation to delivery type, position of delivery?
I do have the delivery stuff.
With the dysfunction?
I do have the delivery stuff down. I will say one thing that's going to be slightly biased is all preterm infants at a certain gestational age are delivered by C-section because there's such a risk of head entrapment. So there's such a bias on like these preterm delivery situations, and all of them have placental insufficiencies. Half of them come from just horrifically unhealthy pregnancies. So we started dabbling and digging in that information, but there are such specific delivery modes of indication based on the weight and the prematurity that over half of these babies were like, I think over 72% were C-sectioned. So I kind of threw that out of the data. I think if I was looking at older kids where I could be like, hey, how did you naturally come into this world without like someone saying you had to come into the world this way? I think I could compare it a little differently, but it's like a predetermined decision for this population of babies for the most part.
Yeah, there's so many times when you can feel a baby's head and go, oh boy, I can feel the OB's hand here.
Yeah,
they were really heavy-handed with their right hand.
For sure.
If you could only correlate that.
I know.
This is wonderful work, by the way.
Thank you.
Congratulations.
Thank you.
I think our next question was from Kimberly Wolf.
Hi, and congrats. So exciting to actually hear all of it spelled out. I've heard like tidbits over the years, and it's so exciting to finally see it and hear it. So congrats to you. I have two quick questions. One was came up while you were talking during questions. How often did you find the severe dysfunction?
Very, very, very rarely. Like almost never. I mean, there were like, I don't know, if I'm guessing like less than 10. Rare. Which is important because I think a lot of times people think of these babies, especially in like, I don't know, allopathic world, just being so locked up, or I feel like the therapists are like, this doesn't move. And I'm like, no, it moves fine. Don't force that, you know? Very, very, very rarely. Most of them were very mild or moderate at the most.
That correlates with my experience clinically. I just wanted to make sure, because again, I haven't had my hands on as many NICU kids. So cool to see.
I mean, if they were severe, they were like the breech babies with their hips totally locked up, and they were born greater than 28 weeks, and they were examined within like the first couple of days of life. And qualified to enroll right away. A lot of the preemies, you know, they were a month or two old before they even got enrolled by that point, or more chronic-y. So depends on the kid.
Awesome. And then one other question, sort of advice, unwarranted, so take it or leave it, but where are you planning to publish?
So we're gonna start with like osteopathic or journals, either JOM or JAO, for the safety data, for just the safety. And then once that one's out, we will go for, you know, Journal of Pediatrics and things that are bigger for the extra developmental, the actual results. So we're going to go for big guns for the true like primary investigative reason of the study, but for the safety, we're going to publish that first. Probably it's a little more osteopathic irrelevant.
Yes. Awesome. That's what I wanted to make sure that you're getting it out, because the world of pediatrics needs to see this data, not just our little osteopathic preaching to the choir. So that's my unwarranted advice, is go big or go home. And let me know if I can help in any way.
I appreciate you.
Awesome. Congrats.
Thank you.
All right. We had a question in the chat from Dr. Dagenhart earlier, but he's also raised his hand. So I'll just pass it over to Dr. Dagenhart to ask his question himself, if he would like.
Thank you. The earlier comment was actually based off of the first question that you answered regarding finding the extremity dysfunctions, that you were surprised that there were a higher amount of that than you would have anticipated. Was there any way that you could have been or were blinded to the amount of lines that had been placed into the baby, or was that pretty?
No, I was not blinded at all, because that was something reviewed and known, and obviously I'm caring for these infants, like either as a fellow or attending as well. So no, I was not blinded to where they previously had lines or anything of that sort.
Great. Now, it would be interesting for a future study from perhaps one of your fellows working underneath you at some point in time, is to look at discharge somatic dysfunction data and looking at its correlation to the presence of those lines and invasive procedures. I think that would help to give some further insight in regards to that association.
Very cool.
So my other question is related to, in your initial one of your, I guess your second slide or so forth, you talked about the fact that physical therapy, occupational therapy, A lot of other groups have already demonstrated some value to premature infants. Is there any possibility, based off of what you've done, that there's any way of looking at whether this was really OMT or whether this is similar outcomes that's done by the other groups?
So I think that our length of stay and feeding differences are substantial compared to the data that is proven from the PT and OT world. Also, PT and OT techniques are direct, like they're very, very direct. Babies cannot tolerate them until a later gestational age, and they're heavy-handed. You know, they involve range of motion testing and positional testing, things that you don't ever have to do within the osteopathic world. So I think one of the biggest sellers is like, we can prove from this that we have pretty good data to say babies at a very, very early gestational age very safely tolerate this, and it has been proven they do not in the other therapy realm worlds, either in massage or OT or PT. And I think that goes to show very gentle approaches that babies tolerate fine can be done and can make a clinical difference super early on. Now, you could always do a situation where babies were getting one therapy and another, but all of our small babies, less than 28 weeks, every single one of them get a PT and an OT consult. It is standard of care in our NICU. So all of the kids in the control group were getting PT, OT, massage. They were getting all of that. And their length of stays and feeding data and all that are not anywhere close to the kids who were treated. So just having that as part of standard of care, those, at least the kids 28 weeks and under, they all got that weekly assessment, sometimes 3 times weekly.
Great, thank you.
Mm-hmm.
All right, and we have another question from Kelly Joy. This will probably be our final question for the webinar.
I always have questions. So, from what you've said, I kind of feel like I've been led to believe that manipulation for babies less than 28 weeks is probably not going to be a great safety kind of process just because they don't tolerate life. Why would they tolerate more fingers? I just want an opinion on what is your thought as a NICU doc about that?
I don't know. I actually think, I mean, that's part of it is like, what do I do now? Do I go hunt down the smaller babies and try to treat them earlier and see if they tolerate it? Do I focus more just on the small baby group and see what I can get, which is probably what I'll do. I'm super interested in neurodevelopmental outcomes, period, like as a neonatologist. So that population fits with my career goals and kind of community approach. Those are our high-risk babies that are at very bad delays and not being able to like integrate into society, which is kindergarten for them. They can't do it. So that's my main target approach area. You know, I think that what data we have shows that one baby's just event. They're just gonna event. And, you know, maybe the stop criteria was a little too stringent. Like maybe we should have done 30 seconds, a minute. Maybe I should have not done such a stringent thing. But in designing this trial, we wanted to do it as like close to no question that this was safe for the babies, especially from the IRB. They were like, what are you doing? So I don't know. I mean, what we've seen is that babies tolerate the treatment time just as long as they tolerate not being touched down to 28 weeks. They very well may tolerate it if I was to expand on that criteria a little bit younger. You know, I think it gives us some range to think about, knowing that it doesn't matter that they were, you know, I even think like, let's say you're a NICU and a feeder grower level 2 institution that's got, you know, like CPAP babies and they're all 34 to 35 weeks or 32 weekers that don't need central lines, you know, like there's a lot of NICUs like that a lot of osteopathic places are affiliated with, not necessarily like really ridiculous high level care stuff here. Those babies, I mean, the big thing here is the study showed that it doesn't matter whether they were born early or not. It doesn't matter what age or what weight they were born at. They all tolerate treatments for about 15 minutes safely once they hit 32 to 33 weeks corrected gestational age, period. So I think that we can say, I actually think there's pretty strong evidence to say babies do just fine, treated or not treated at this small of an age. So you may could squeeze it down. I don't know. I don't know that that's worth trying to prove and do. Most babies are so eventy. I probably wouldn't target them from other standpoints for that reason, but I think it would be safe.
Can I ask a quick follow-up?
Yeah.
What are your thoughts about those other babies that had head bleeds or had surgeries or things like that? Those are the dysfunctional kids.
Right. I think
So
this was like the first US study to prove that this was also safe. So I think now that we have some grounds to say like kids were not harmed from this, and if in fact have less events at certain gestational ages getting treated, that we have grounds to say it is safe for everyone. We have an entire cardiac ICU here for babies and stuff. I think those kids particularly would greatly benefit from this. And now I just kind of willy-nilly get asked and pulled in for consulting on these kids all the time. And our unit is more used to just knowing it's a thing and it's safe for people who know what this is and think about it. At the time we rolled out grade 3 and 4s, not just because of their predisposition for neurodevelopmental delays, but because the attendings were pretty uncomfortable with me treating active head bleeders. I don't think they would say that now, seeing the IVH rates had to be altered and you know, take into consideration like things were balanced in these groups almost negatively to the treatment groups because the confounders were BPD and IVH being lower in the treatment group. So even balancing that out, they're still statistically significant. So, you know, I don't know. I think that those kids could greatly benefit from this and would do quite well.
thank you so very much. What, you know, we are even doing cranial research for adults in head bleeds. And that was something whenever I was in medical school was like, but we don't do that. So yeah, thank you.
Yeah, thank you.
Well, unfortunately, our live discussion time is up. So don't forget that this webinar is being placed on the DO-Touch.NET's YouTube channel where we can continue any discussion or questions that we have. Just watch for an email for an announcement when that recording is available. And thank you again, Dr. Tyson, for this wonderful presentation. Just a couple announcements before we go. The first announcement I just want to say is that we did send out a quick survey to our members, just double checking on these Let's Talk About OMM research time schedules coming into the next year, 2024, just to make sure that this time, that third Friday at noon still is the best time for our members. And so if you could please just respond to that whenever you have a chance. That just lets us know at the coordinating center what time is working best for you all to have these continued webinars and everything, and what kind of schedule we want to keep going into the next year. And our next episode of Let's Talk About OMM Research, our last one for the year, will be a journal club on December 15th with Anne-Marie Zeller. And it'll be on the article titled Retention of Tissue Texture Change After Cervical Muscle Energy and High Velocity Low Amplitude Intervention, Implications for Treatment Intervals. And we look forward to seeing you all then. And thank you very much for attending today.
Thank you, everyone. Have a great day.
Thank you, Angela.